the acting director of the Center for Health Services Research. We're going to record this, which I assume is okay. Lars said that he was okay with that, and post this to the CHSO website. Let me just introduce Lars Peterson, who is on the Zoom here with us. You can see the map behind Lars. And he is a senior physician scientist at the American Board of Family Medicine, which is actually headquartered here in Lexington, but certifies almost every family medicine physician across the US. And they do great work, and we've been collaborating with Lars and the ABFM for our Rural Health Research Center for, I guess this is the 9th year. He also is a professor in family and community medicine here at UK and happens to be chair of a review panel for the Agency for Healthcare Research and Quality. And I invited him to speak with us today about, in general, what AHRQ is interested in funding. And I think this is a potential avenue for many health services researchers to submit applications to. Although I looked up today an NIH reporter, and we only have one active grant from AHRQ here at UK, and that is held by the new chair of pharmaceutical sciences, or pharmacy practice, excuse me, in pharmacy here. So nobody who's been at UK for a while has an active grant and from AHRQ. And I think this points to the opportunity for us to pursue funding. And he will also speak to his experience about the review process, which I think would be valuable to anybody who is submitting a grant to any institute or agency. So let me turn it over to Lars to continue for today.
All right. Well, thank you, Ty. I do have slides that I was going to share that I can also send out. So people, I just want to verify, Ty, you can see the correct screen of a slide. Okay.
Yes.
I got to verify with the two screens. So thank you, Ty, for that introduction. You already stole my thunder. I was going to talk about the ABFM and like what we do, but you already did it. So thank you. And without me prompting you, so you've learned over the last 12 years, which is awesome. I guess no other introduction needed. Ty did a really great job. And so I will try to advance. There we go. Skip past. Okay. So objectives, as Ty mentioned, is number one, to talk a little bit about AHRQ kind of funding priorities and their role kind of in funding federally supported research, and then talk about the AHRQ review process. So I will say, when Ty asked me to do this, I told him I would only do it if I could get some help from the people at AHRQ who make this work. So I have a scientific review officer whose name is Michelle Carlton, who manages the committee and does a lot of the work I'm going to talk about. And so between her and the director of scientific review, Celeste Torrio, they gave me a couple slide decks that I kind of cobbled together and rearranged to make this talk. So I have to definitely give praise to them, because I don't think I'd be giving this talk without it, because I wouldn't put this whole thing together probably near as well without using their existing slide decks. So why won't this go? Okay, so just a word about AHRQ and their mission. Their mission is to produce evidence, make healthcare safer. Definitely patient safety is a big part of the AHRQ mission. Higher quality healthcare, make healthcare more accessible, equitable, and affordable, and to work within the Department of DHHS to make sure that evidence is understood and used. And I'll come back to that understood and used part frequently. So in thinking about other healthcare agencies, I was trying to find a better slide and resources comparing AHRQ with NIH. But if you think about the kind of the realm of public agencies that fund healthcare research that some people are able to get grants from, like the CDC, obviously does a lot of work on population health and public health issues. The FDA does a lot with drug safety, and NIH, if you think about that as research for cures, and AHRQ likes to say, research for care. And that distinction goes a long way in terms of AHRQ focusing on the delivery of care more than, the discovery of cures. Obviously, if you're going to do a grant that's focused on, understanding the phosphorylated pathway signaling of, gosh, I don't even know, something along those lines, to do a bunch of molecular research, that wouldn't even fly at AHRQ because that's just not what they do at all. But there is some overlap in terms of what they will fund in terms of studying health systems, because a lot of that still does get funded by NIH, which has a much larger budget than AHRQ. So a lot of people will try NIH in addition to AHRQ for some grants, so there can be some overlap between the two. And so further with AHRQ's vision and mission, obviously, the overall vision of AHRQ is to improve the lives of patients, and to try to do that through helping, healthcare systems and professionals deliver, again, hitting the part of safe care, higher quality care, and higher value care. And they do that through, intramural research, extramural funding of research, and also creating some data systems and resources that other people can use. So part of their focus on health systems research is obviously what we do, investigator-initiated research, sending in grants that they will fund. And then they have additional targeted investments and calls for that right now. There's a new call for grants to understand the science of primary care, which as a practicing family physician and someone who loves primary care makes me happy and excited, because AHRQ has been where a lot of kind of family physicians have got funding in the past. And family physicians don't have a monopoly on primary care, general internal medicine, general pediatrics, nurse practitioners. There's a lot of potential work in that space. And that's been met with quite a bit of excitement. In my own study section, we've gotten quite a few of those applications over the last 3 cycles. And to increase the volume, as I'll get to, actually I'll just say it now, it increased the volume quite a bit. We usually get about 30, kind of mid-30s number of grants to review each section, and this last time we had 56, which was quite a jump. And there were about, somewhere in the mid-teens related to the primary care call, which anyway, made me happy. And then also, again, a focus on patient safety, looking at, correct diagnosis, healthcare-associated conditions, antibiotic resistance, digital health research, particularly functioning of electronic health records and kind of e-health, and then opioids. And so I mentioned I was going to bring back that make sure evidence is used and understood line, because they do fund practice improvement or quality improvement kind of studies or projects, not to say, we know what we're doing, but how can we actually implement it in practice and make sure that care is actually delivered right, rather than just understanding, this is the best way to do it, but what are the barriers to actually doing it in terms of dissemination and implementation grants and funding. And I mentioned AHRQ has a lot of data resources as well. If anyone's used the MEPS, or the Medical Expenditure Panel Survey, AHRQ runs and maintains that, as well as HCUP, which I know has been used in the College of Public Health by a number of investigators using that data set. Also, they have some disparities reports, and then they've created this new, it actually wasn't on the slides they sent me, so I added this compendium of U.S. healthcare systems. They've added some updated data now where you can actually link, which is fascinating, and over what I do looking at family physicians and what they do in practice, you're able to link a particular physician via their NPI number to kind of what practice they're in, and also with they're in a certain healthcare system, to allow a better understanding of like healthcare systems and linkages between individual clinicians and what systems they're in, which is pretty exciting. And AHRQ led that support, the creation of that. Also, they have other databases on social determinants. And then they used to be called the PQIs, Performance Quality Indicators. I think that's the Comprehensive Health Systems. Anyway, they have data on kind of area level data about things like asthma, preventable hospitalizations, the different geographies you can get off their website that can be used for research. Another, just thinking about the continuum of grants and mechanisms that AHRQ has. They go all the way from training awards, so dissertation awards, career development awards for K awards for early career and later career, and then the smaller investigator-funded, investigator-initiated studies like the R03s, R01s, and the R18s. There's the dissemination and implementation grants, and then R13s being the conference grants. And one thing they don't have is an R21 mechanism, kind of fitting that between the R01 and the R03 that NIH does, but AHRQ does not have that particular mechanism. So their research priorities, again, was probably hitting the same point, patient safety, improving healthcare with a focus on patient safety, data and technology, so the health information technology research, and then, trying to increase accessibility and affordability of healthcare and understanding those things. So then going into how scientific review works at AHRQ, I'll get to the next slide, but there's basically an initial review group that looks at all the grants and then sends them to one of 5 standing study sections. They do have an occasional special emphasis panel for particular calls where they convene a group of experts just to review grants for a particular call or mechanism. But there are 5 standing review committees, and I'll get to a little bit about how grants are routed to different committees at the end, or a little later. So I'll go through a couple of them in order, and this is just kind of off AHRQ's website. There's all the meeting dates, the roster of who's on the website, and information about kind of what topics are covered are all on AHRQ's website. You can look at each of the study sections. But there's one, Healthcare Systems and Value Research, HSVR. Ty said he's recording this, but I'll still make this joke. As a clinician, I see HSVR, and I've been telling this for years. It reminds me of herpes, because as a clinician, that's HSV, or herpes simplex virus. That's the first thing that comes up in my head, and I've told them. Glenn Mays, who used to be at UK, is actually now the chair of this study section, and I told him he should work to try to change the name as to not recoil certain people. And actually, interestingly, Glenn must be either a glutton for punishment or really into service, because he had just finished being a chair of the training study section, and agreed to be the chair of a different study section. So really good guy. So anyway, this is kind of what they focus on in terms of organization, clinician workforce, access and utilization, cost, finance, et cetera. And then I mentioned health information technology. So there is a study section focused solely on this in terms of, building EHR tools, how we can make electronic health records and other global or digital technologies work better for patients and systems. There's one, HSQR, in terms of the focus on patient safety and quality improvement. They also have an interesting focus, in addition to safety, on antimicrobial resistance and stewardship of using antimicrobials responsibly in practice. And I was mentioning about AHRQ, people from Kentucky getting AHRQ grant reviews. I'm not the only person from Kentucky on a study section. Daniel Moga from pharmacy is a standing member of HSQR. This is FYI. And then this is the healthcare research and training. This is where most of the K awards and the dissertation awards go. And this is the one that Glenn used to be the chair of. And anyway, they focus on that. And then finally, of course, the best study section, I will say, is HEOR, or Healthcare Effectiveness and Outcomes Research. The one I was on as a standing committee member from 2016 to 2019. And then in 2022, they asked me to, I was invited to come back as a chair for 4 years. So I'm now just a little bit over halfway through my service there. And so we do a lot of great, I think it's awesome, the things that come through in terms of outcomes research, organization of care, delivery of care, quality of care, et cetera. It's a real, I learn a lot every study section. So who's on these things, right? How do people become reviewers? What are their qualifications, et cetera? And so AHRQ, will tell you every reviewer has to have appropriate expertise and competence needed for the study section. And obviously there's a different focus for each study section. So there's different types of expertise and people on each study section. So there are, I mentioned, standing members, and then there's ad hoc members. So this is usually, well, anyone would have to meet these requirements, but then you can become a standing committee member where you do a defined commitment of service or defined term of service, anywhere from 2 to 4 years on the committee. But to do that, you've got to have some scientific credentials, have a reputation for doing quality research, have a good publication record, kind of a reputation that you'd be a known person. have some kind of achievements. And also, and I didn't ask how they determine the other competencies, like these kind of softer skills. I know when we do have ad hocs who come in, kind of as a one-off, sometimes I'm told by the review officer, well, we're kind of, trying them out and see how they do, to see if they, how they work in a meeting and how they do, the quality of the reviews they do and the conversation they have in the discussion section, see if we then want to offer them a full standing committee position in terms of being able to work in a group and, get your assignments done, et cetera. And so for each committee too, there's a mix of people. So on HEOR, we have, I think, about 20 standing committee members. And so there are people with, for physicians, kind of different clinical expertises. I mean, I'm a family physician. We have a nephrologist, an oncologist, a general surgeon, a pediatric hospitalist, a med peds, kind of primary outpatient physician. We have other nursing researchers, we have pharmacists, and then we have obviously PhD researchers of different fields like human factors research, qualitative expertise, et cetera, kind of to cover the range of grants that will come in. But if there's not so if a grant does come to a committee where there's not someone with an expertise on that topic, that's where we'll use some of the ad hocs to make sure there's someone with expertise to review that grant. A recent example was we don't have an OBGYN on our panel, and we had a grant that was related to deliveries or maternal child health, and so we recruited an OBGYN to come in as an ad hoc to help us out with that particular grant. So I was going to have this slide up for a sec because I was going to talk a little bit about now how grant review works at AHRQ. And so if you've done your part as an investigator, you've done your research, written up your awesome proposal, and decided you're going to send it to AHRQ. Probably should have done long before you started writing it up, but you send it in. So what happens then is it goes in, and that initial review group will look at it. And then review kind of the topic, the general theme of it, ensure there's not some like major conflicts. Like if I send AHRQ grants in, they can't come to my study section. That just, create kind of problems. And so then they'll assign it to one of those 5 review committees. And then from my perspective, from what happens to me as a reviewer, then about 6 weeks in advance of the meeting, my scientific review officer, we get an email saying the grants are up, and we need to go check our conflicts of interest. And so then I have access through ERA Commons to go in and look at all the grants, so I can see the titles of the grants and all the named personnel on the grants. So then I need to check for conflicts of interest. So obviously with the institution, even though if you're at the University of Kentucky, if I've never met you, I'm still in conflict because I'm at the same institution and you don't want to be seen as trying to steer funds to your institution. And then other conflicts like, regular collaborators, co-authors, mentors, et cetera. So you have to go read through all the grants and put conflict or no conflict. Or if there's a kind of a gray boundary, like you're not sure, like, I wrote a paper with this person like 4 years ago, but I might not have ever met them. Like, does that qualify or not? You can say need to discuss with the scientific review officer and kind of have that discussion and make a decision. So then after you do that, it takes, they give you a week or two or a week or so to do that. And then the review officer looks at the conflicts, looks at the grants we have, the expertise of the reviewers, and then makes assignments. And so depending on like the volume, me as the chair, I still have to actively participate in the grant review process. So each section, I'm usually assigned 3 or 4 grants to review as the primary reviewer. Other reviewers tend to get somewhere between 6 and 8, depending on the volume, grants to review. And there's a difference between being the primary reviewer, the secondary reviewer, or the third reviewer. So it's a little bit more work as the primary reviewer. Well, I'm kind of skipping ahead. So the review officer does all that and then makes the assignment. So then you get notice again that in ERA Commons, you have your assignments, then you can go and look, you can see which grants you were assigned, and then you'll have access to the actual application. So then this is where I already have for our meeting in February, I already have 4 blocks of time on my calendar blocked out. So I have 3 hours per grant blocked to do reviews. I know some people, when I've talked to different reviewers, will do them faster, but I don't know. I'm a slow reader, always have been. So it takes me about 3 hours based on experience to do the average R01 grant or R18. R03s I can do a little faster. It also depends on the quality and on either end about how I do that, and I have to write the review. And then for each of those, then you get to see if you're the first reviewer, secondary reviewer, the third reviewer. If you're the primary reviewer, it's a little heavier responsibility in terms of being the person who would be leaned on in the meeting to have the best kind of understanding of the grant, answer questions. You'd be the person who'd be deferred to, should have a deeper understanding of the grant. So take that a little bit more seriously and have better notes. And so for each of those, there is a template that they provide for the review. And I'll get to the criteria on a future slide. That we go kind of by different things we review. Actually, yeah, now I'm going to transition to that. Yeah. So what you're supposed to do then, they give a template for each review, which is nice because then it has specific criteria for each notice. So for each mechanism, there can be slight differences, and then depending on the notice, like for the primary care call, there's specific things they want to know about in the significance and the approach that you need to address in your critique that you don't need to necessarily do for just a general R01. So you have to pay attention to that. And obviously, you review the grant based on what's in the grant. You can't base, if you know of the person or kind of knew them tangentially, you can't base your assessment on like things you know about them. You have to assess the grant as written. Last year, we had to do some kind of bias or unconscious bias kind of reviewer training last year. And part of that was watching a study section, like a mock study section. And it was an NIH one, and they were reviewing, a grant by Dr. Fauci. And basically, Dr. Fauci didn't do a very good job writing the grant. And they were trying to show that you can't just default because it's Dr. Fauci. You say, well, just trust him. He'll be able to figure it out, right? If they write a bad grant, you got to give them an appropriate score. It's kind of the guidance they always give us. And then also the process of independent review. This is an independent scientific review, so we don't use the F word or the funding word in there. We just give a review and a score, and then there's, after the reviews, if you score in the kind of near the cut line of funding, there's another council of AHRQ officials and staff who make the final decisions about whether or not you'll be funded. So when you get a grant, this is all public. You can look up kind of the review criteria for each notice as well on AHRQ's website. We assign an overall impact score from 1 to 9, 1 being the best, 9 being the worst score. And then we also score individually on different criteria in terms of the significance. So like, is the grant expected to kind of move the field or change the field or contribute to public health or improve care as delivered in the field? It's quality of the investigators and their appropriateness to do the work as proposed. And that was actually another thing on the bias training, that there was, concern that, just don't always think if they're at Harvard, they're great, right? So kind of actually look at the training they have, or they come from like a lesser known institution, just, make sure that they have the training and skills to do the project, not based on other things. And then innovation, is it kind of moving the field, advancing theory, challenging paradigms, et cetera. The approach, the rigor of your methods, and the scientific basis and premise for the study. Then the environment, environment's rarely an issue because most of these come from, top R1 research institutions. So usually that's the score. I'm always like kind of 1 or 2 on environment. And then there's some additional criteria that I'll get to on the next slide that you don't assign a score to, but can influence your score. So in AHRQ, those are protections for human subjects, like you have an adequate IRB plan that meets muster. Are you including or addressing priority populations for AHRQ, like primarily underserved minority populations and low SES? And then degree of responsiveness is a notice of funding. Like if you put something in for the primary care study and it's, about the delivery of, rheumatology care and rheumatology practices, you're going to score really low because it's not responsive to the notice. And then things that don't affect your score but are discussed and feedback is given is the budget, If it seems like excessive or too long or not enough, that will come up often too, that, maybe they don't have enough resources to do part of the grant. And then a data management plan about how you're going to manage the data and potentially share it later. So reviewers, so you have to write up a whole thing about that, about everything as a reviewer, and then go into make your score. And the score, so you have the individual scores from 1 to 9 and an overall score. And the overall score doesn't have to be an arithmetic mean or kind of average of the other scores, because you can really have something that's, great significance, could be a great study if it's pulled off, and really move the field, a fantastic group of investigators done at a great university, but just has like a fatal flaw in the methods that you're like, they just got the wrong data set, or they're just doing something that's not going to answer the question, but everything else is great. So you could have like a 1, 2, 2, 7, 2, and give the grant a 7 based on that like really major fatal flaw, but that would hopefully be remediable. And then, this is the part about the overall impact not being the arithmetic mean. And so then you do that work at home. You go and then submit your scores, and they give you, like I said, a couple weeks to do it. And for our grant review committee, we usually meet on a Wednesday and Thursday in HEOR. So usually it's the Friday before. You have to have all your grants in by midnight. And then you get an email back, and it's kind of fun because then you get to go in and see the other reviews for the people who reviewed your grants as well. And so then your job to prepare for the meeting is to then go read the other grant reviews, see what the other reviewers said about the grant, were your scores aligned, not aligned, and if they were not aligned, kind of help understand the differences about, did they see something you didn't? Was it just or kind of a differential interpretation or weighting of the weaknesses as either minor, moderate, or major that led to the different scores? And then be prepared to discuss the grant in the meeting, which you might not have to do, probably shouldn't do if all the scores were like 7, 8, 9 or something like that. But if they're all like 1, 2, 3s, you should definitely be prepared to discuss it. And so then as chair, my role is a little bit different. So the day before, I actually will go in and I'm able to see all the preliminary scores except for the ones I'm in conflict with. And I go in and I basically look for discrepant scores and look for where I can guide the meeting and understand the differences between like if a grant was a 2, 2, if the overall scores were 2, 2, 6, and I know that one's going to get discussed, I'll go and read all the reviews, read parts of the grant to kind of understand the differences between the reviewers to help then guide the discussion, to make sure that differences are brought up and adequately discussed during the meeting. So that's what I spend a lot of my time doing and taking notes the day before, in addition to preparing to discuss my own grants I have to discuss. So then on the meeting day at AHRQ, the first thing we do, kind of the most boring part, is the part called triage. If you've had a grant come back as ND or not discussed, it's always a little bit painful, but that's kind of the first thing we have to do of like all the grants that are there, which ones are we not going to discuss? Because we can't discuss them all unless we met for additional day or two. And so prior to the meeting, AHRQ staff actually will go through from all the preliminary scores, and within mechanism, which is how AHRQ does it, they'll kind of look at the preliminary scores and rank them. And within mechanism, so within RO1s, we try to discuss the top half of RO1s, the top half of RO3s. And so the cut line can be different based on the mechanism, kind of who you are in the pool with, which can lead to some interesting things, like, an RO1 that scored or had a preliminary score of like 3.9 or something might not get discussed because there were some really good grants that came in at the same time, where in that same session in RO3 that scored like 4.7 or 5 point something, could potentially get discussed depending on the relative strengths of the other grants. And so the boring part is I have to go through one by one and name every grant that is nominated for triage, as we call it, so to not be discussed, kind of one by one. And then at that time, any reviewer on the panel can say, I want to save it. I want it to be discussed. And you're not supposed to say anything at that point further because every reviewer is in there. So even the conflicted reviewers aren't even supposed to know who the reviewers are. So you can't say, I want that discussed because I'm reviewer number 1 and I gave it a good score. Like, I'll cut your mic off and shoot you in the dead eye or the laser eyes at that point, because you're not supposed to say anything like that. And so that we have to go through that whole process, and then we get the review order, and then we proceed with the reviews. In my panel, we discuss all the mechanisms together, like we usually do all the R01s, all the R03s, and then the R18s, and then end with the R13s or the conference grants. And each grant's allotted 20 minutes on the schedule to discuss. We let that vary a little bit depending on how much disagreement there is, the discrepancy of scores, et cetera. And generally, R01s take a little bit longer than R03s, but it's 20 minutes. And so then I start, I got to remove the conflicting reviewers. And then when they're out of the room, then call on the reviewers to give their primary scores. And then the first reviewer takes 5 to 7 minutes to kind of briefly describe the grant and its purpose, and then the major score driving strengths and weaknesses that led to their score. Reviewer 2 takes about another 3 to 5 minutes to add any additional information that the first reviewer didn't, or highlight where they're in disagreement. And then the third reviewer should be 1 to 2 minutes if there's anything additional left to say. That should get us to around 10, 11 minutes halfway through the 20, and then we open it up to discussion amongst the panel. And then after that discussion is felt like either would come to a close or, start kind of repeating ourselves, then I call it to a close and then ask those score driving questions that aren't scored, like, human subjects, priority populations, responsiveness. And then I have to give a summary of the grant about the kind of the key points driving the discussions and weaknesses. That the scientific review officer will then partly use my summary in their notes to write the critique you get back. And then after that, I ask for final scores. And so if a grant was a 262, the reviewers get to say again what they want to do or where they want to move to after the discussion, which there often is some movement, but the goal isn't consensus or unanimity. It's just to make sure differences are discussed and addressed and understood. And so if it remains 262 after that discussion, then all the people on the panel get a vote, and we ask if they are going to vote within the range. You can vote outside the range. Like if you heard something that really bothered you and you thought that was a major flaw and that grant should get a 9, you can vote at a 9. You just got to raise your hand and say, yeah, I'm giving it a 9, and email in. And then we just go through that whole day like that. And then once it's done, if you change your scores, you have to update your narrative and your scores and reload them into IAR a couple of days later. And honestly, that was it. This is the only picture I have. We do study sections, like I said, once in person in October, and the other 2 are virtual. This was my last meeting back from my first term of service in June of 2019. There's only 2 of us who are the same on that from the review panel to now. So I will stop sharing, I guess, see if there's, I've been watching, I haven't seen any questions or anyone pop up, but yeah, I'll stop sharing and see if there's any questions.
I had a question, Lars. Nice to see you, and thanks for the
Yeah,
presentation.
good to see you.
I was just wondering the priorities of HRQ. You listed opioids there, but I don't know, like, are there many grants being funded by HRQ on those? Because I know in the past, HRQ mostly funds things close to like safe patient safety, quality improvement, healthcare systems, that kind of areas. So I just wanted to kind of get an idea in terms of research priorities and now what are likely to be funded by HRQ. Are there any room for like SUD, like, substance use related work in HRQ?
I would say based on what I've seen in grant review panel, yes, there's interest because we have grants that have come through on like opiate use and reducing harm and addressing prescribing and deprescribing. Those kind of things have come through.
Okay.
Yeah. So I can't say for certain because I'm not the program officer, but I know obviously someone's
I
gotten
understand.
positive
Yeah,
feedback.
I just
Like,
kind of
yes,
wanted
you
to
should
get
send
it.
it in, yeah. And
Yeah.
then I'll tell you,
Okay.
it's a little frustrating too. And we brought this up at grant review because granted there's a lag between when things are discussed and when they're funded, but we never actually ever get feedback or like a final confirmation, like, hey, you know, that grant you reviewed, like in, you know, February of 2024, it was funded. Like I'd have to like keep a list and remember and go look them up on NIH Reporter. So you never quite get that final, like, did it really get funded or not? It's kind of like
Yeah.
a happenstance. They do tell us in general, like out of our study section, like kind of what percentage of grants that were discussed there ended up getting funded over like a whole calendar year or review cycle. But yeah, we don't get that level of specificity, which I've told them I might enjoy getting, but I guess maybe not a lot of other people want that feedback. So yeah.
Sure. Thank you.
Yeah, well, thank you.
Any other questions about AHRQ or just review processes in general? So any thoughts, Lars, about how we might encourage people here to submit more applications to AHRQ? I wonder if people just don't know about this opportunity as much, or maybe, you know, UK is pretty concentrated on the particular areas of investment, which align with, you know, NCI and NIDA, et cetera. So because it's a little bit more general, I wonder if people are just not tuned into it.
Yeah, and I think the problems that AHRQ suffers from, and this is where when I said I was trying to find slides to talk about AHRQ versus NIH, is there's some, I mentioned it's like budget is far smaller. I think AHRQ is, I mean, I know in primary care, like in family medicine research circles, there's been efforts to, you know, quote unquote, billionize AHRQ, which I still keep wondering if $1 billion would be like a rounding error at the NIH. I mean, it's a very small compared to the total body of NIH. And so there's also some different rules in terms of AHRQ, like your indirect costs come out of the total grant cost in AHRQ, whereas at NIH you get the total budget and then the indirects are on top. And so I know from a budgeting perspective, your grant review office and things might say it's better to try for NIH just because of that budgetary difference and the ability to get more resources out of a comparable grant. And then also, if I could be, you know, I know you're recording this, but I'm not saying that it's not kind of publicly known, right? I think there's also that prestige factor, right? When you're going up for promotion and tenure, saying, you know, I'm NIH funded and have all this NIH dollars is a little bit more prestigious than saying I'm, you know, regularly funded by AHRQ. Just because that's some kind of built-in bias that persists, whether or not it's valued or not, because I personally would love to get an AHRQ R01. And would celebrate that immensely. So I think it's just a little bit of that structural barrier in terms of AHRQ having different rules and not being as generous with their fund, or able to be as generous with their funding as NIH. And then just, yeah, perhaps a little bit of lack of awareness, or just investigators kind of narrowing in, like on a, like you said, like an institute. Like if I'm doing cancer research, like, you know, I should just do everything through NCI, or if it's like I'm looking at Aaron's nice bow-tied photo, like thinking about colorectal cancer and thinking, well, I go through cancer, or maybe I do something through the NIDDK, and not think about AHRQ. But
Yeah. Any other questions or comments? I see, who is Chris? Is that Chris Delcher? Nobody's responding.
Sorry, no, it's not.
no, it wasn't Chris Delcher. Yeah.
All right. Well, I think it's you know, I think it's another avenue to pursue. And Gianni mentioned substance use disorder, and when I looked up the only current award to UK was by Dr. Abraham in pharmacy, and it had to do with some sort of implementation of opioid use treatment, I think, in emergency rooms. I just kind of glanced at the title. So it may be another mechanism. And, you know, thanks for coming today and sharing your experiences as a chair of this review panel.
You're welcome. If anyone's interested in being a reviewer, I can always, hook you up with the person who can put your name in the pool.
All right.
Yeah.
I guess that's it for today. So thanks again, Lars. And
All right, you're welcome.
for those of you who are interested, I might put a plug-in reminder for this. We are hosting a kind of health services research connector session in November 15th, for like 3 hours, in which we're trying to bring people together to talk about common research ideas. And it will be sort of in structure, but informal in many ways. And then after that, following that, we're planning to release a pilot study program announcement, which will pay for up to $25,000 per pilot study. But we were thinking that the event in November might stimulate some collaborations that could lead up to some submissions for the pilot study program. All right. Well, I guess that's it for today, and everybody have a nice weekend.
Great, yeah. Thanks for
Thank
coming,
you.
everyone.